Good evening, everyone. We welcome all of you to the second day of the third masterclass on chronic pancreatitis. These masterclasses are being organized by Jaipur Surgical Tutorial, which is an online education portal that we started at the Mahatma Gandhi Medical College and Hospital about 2.5 years ago when I moved from CPGI Lucknow to Jaipur. And all these activities are being coordinated by my young faculty colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery with me. He's been conducting and organizing all these activities. So we conduct a session every day, 9 to 10 Indian time, where students present cases. Sometimes they present an operative surgery session. And very occasionally we have a faculty lecture or an open house session. And anybody can join the Jaipur Surgical Tutorial for free. In between, I will be projecting a slide which will give the WhatsApp number of Dr. Anand Nagar. You just have to send him a message and he will add you onto the group, and then you will receive all the information about all the sessions of Jaipur Surgical Tutorial. So with that brief introduction about JST, I would hand over to Dr. Thomas Varghese, who's at the Malabar Medical College in Calicut, to chair this session. And the speaker is Dr. Roop Jyoti Talukdar, who's the Chief of Pancreatology at Asian Institute of Gastroenterology in Hyderabad. Over to you, Dr. Varghese.
Thank you, Professor P.K. Kapoor. At the outset, let me thank Professor Kapoor for having invited me to chair this session. It's a great session, and it's an online opportunity not only for the faculty but also for the students all over India and all over the world to learn more about pancreatic disease and other surgical disease as well. Today we have an interesting topic: how is our chronic pancreatitis different from that seen in the West? And the speaker for today's session is Dr. Roop Jyoti Talukdar. He is from the Asian Institute of Gastroenterology, Hyderabad. So after his initial studies from Guwahati, Assam, he went to USA, where he did his postdoctoral studies and GA fellowship from University of Minnesota and subsequently from Mayo Clinic. He is a person who is very much interested in pancreatic disease. That is perhaps the only clinical pancreatologist in the country, where he devotes his entire time for the study of pancreas. There is a lot of interest in the various types of acute pancreatitis, different types of chronic pancreatitis, its management, its genetics, the microbiota, and of course, in basic research like stellate cells in isolation of stellate cells and its importance in pancreatic disease. And he has lots of publications, and he is the reviewer of around 20 international journals. So you have the best person to discuss this topic, and without much delay, I will invite Dr. Roop Jyoti Talukdar to deliver his presentation. Over to you, Dr. Talukdar.
Sure. A very good afternoon, very good evening, and let me thank Dr. Varghese for the kind introduction. And of course, I can't go without thanking Dr. Kapoor for this kind invitation and opportunity. So a very interesting topic assigned to me today. How is our CP different from that seen in the West, or is it really different? That might have lots of therapeutic implication, mechanistic implication, and as we go on through the talk, we'll learn more about it. So let me begin. With the story of a disease that has been there since several decades, that is still spoken about in the West, even in India. It's written in the books. There are book chapters, articles, but many of the younger colleagues or the new age physicians have probably not seen that. And there is an implication why I begin the story with this today. So what happened way back in 1955, 1959, disease entity from Indonesia was reported by someone called Zuidema, where the disease was like young, and the same phenotype was actually evaluated in great detail by Dr. G. Varghese in 1962, and he published the data which made this entity globally recognized, and that was called the tropical chronic pancreatitis or tropical calcific pancreatitis. Lots of nomenclatures were given during that time, but eventually the TCP or the tropical chronic pancreatitis stuck on. And the specific characteristics of this disease was the patient had very severe pain during childhood, diabetes in adolescence, and death in the prime of life. So these are the trio or the triad of the classical disease called tropical chronic pancreatitis. So initially it was thought that it's probably localized or seen in the tropical region of the eastern world, but then eventually papers came out later in 60, 63 and 76 from African and countries from South America. And then it appears that it's more of a disease related to the tropics. And then this is, I would call, a landmark study by Professor Tandon, my mentor, who had systematically evaluated this study with his DM student, then DM student, Dr. Balaji in Kulon district. And what they did was they went to the village in the Kulon district, and more than 6,070 families they screened, nearly 30,000 individuals. Out of that, 36 patients were found to have chronic pancreatitis, which was confirmed later on by bringing them back to the hospital and doing other further tests. And so this brought up the incidence of chronic pancreatitis or prevalence of chronic pancreatitis in India as 126 per 100,000. This is a very commonly quoted number even now. But I think now this number has changed because this study was done only in a limited population. But if we talk about a pan-India population, these numbers will most likely come down. But nevertheless, this is much higher than what we see in the West. So this is one of the difference. The prevalence of chronic pancreatitis in India is much higher than we see in the West. And if we see the characteristics of this disease, it was drastically different from alcoholic chronic pancreatitis, which was seen in India and even in the West. The patient's socioeconomic status were usually poor. Almost all of them had diabetes at some point in the disease course. It was a very aggressive, accelerated course compared to alcoholic chronic pancreatitis, which was much slower. There were big chunks of calculi in the large ducts. Almost all the patients had calculi. There was marked ductal dilatation and significant gland fibrosis. So this made this disease very unique and different from alcoholic chronic pancreatitis. Several factors, etiological factors, had been ascribed, like cassava, which is tapioca, which used to be the staple food of many of these people in this endemic region, not only in Kerala, but all regions in the tropical belt. Malnutrition was supposed to be one of the etiology. Familial, because there was 8% patients with clustering of this disease, and few genes like REG1 alpha, REG1 beta were ascribed. But eventually, over the years, several studies have actually disproved these. So these were not really specific to this disease, and even people who are not having these risk factors had similar type of chronic pancreatitis. So what happens? This is very interesting. When the days passed, and Dr. Balakrishnan is one of the doyens in pancreatology in India and the world, and he has published seminal papers, and he and his group actually followed this patient of the same biological behavior over a decade. So what came out in 2004 was when they evaluated the same group of patients from the same population, same kind of risk factors. What came out was that the mean age of the patients in 2004, same biological behavior, idiopathic or tropical pancreatitis, age was 30 years compared to 20 years in 1984. The BMI improved, meaning the patient's nutritional status improved. The socioeconomic status was also better in these patients, and diabetes was markedly less compared to what was seen in 1984. So what does that mean? That there has been a change in the biology of the disease, or are these diseases really tropical chronic pancreatitis, or has there been a change in the disease? So now let's come to the recent modern era. What kind of disease do we see now? So this is data from the Pancreas Clinic at AIG, almost 900 patients from two time periods, 2012 and 2019. And this is the distribution of patients that were included in this study from all over India. Majority was from the south and the east. And what we see here is, if we see again, the distribution of patients, the the patients from South, excluding Kerala. This is a different set from Kerala 2006 data. Then Eastern India, Northeastern region, and the other part of South India. If we see the mean age of onset now is almost similar. In fact, in Kerala, it's a bit later than the other parts of India. BMI is similar. They are not malnourished. Socioeconomic status, all of them are from the middle socioeconomic status compared to the lower socioeconomic status in the tropical calcific pancreatitis. Prevalence of diabetes was similar with a higher incidence in Kerala in 2006. And the mean disease duration between the symptom of onset and diabetes were also similar. And the morphology of the disease was similar. So now it appears that we are dealing with the same kind of disease all over the country. And they are not following, or they are not showing up the typical morphology of what used to be called as tropical chronic pancreatitis. So there has been a change in the disease behavior. The TCP was supposed to be a disease of the young, very, very young onset disease. But so when we compared the disease behavior between patients below 30 years and above 30 years, again, we don't see any significant differences between the biological behavior and the demography of the disease. So similar proportion of patients had weight loss, and BMI was similar in both the groups. Diabetes, of course, was more in the patients with over 30 years. That could have other etiological factors also. Some of them may be having type 2 diabetes, or because of the duration of the disease, probably they have more of diabetes. Dilated, again, morphological changes were similar in the form of dilated main pancreatic duct and presence of MPD stones. So again, we see a similar kind of disease between patients who are below 30 years, who has onset below 30 years, and who had onset above 30 years. So now what we see, what we have now, we earlier saw a disease, very severe form of chronic pancreatitis, early onset brittle diabetes, early death, localized to the tropics. Now we see a disease which is much milder compared to the TCP that we saw earlier. Onset is delayed by a decade. The diabetes is controllable by OHAs, and all of them are not brittle. Longevity increased, and they are not localized to the tropics. So what's going on here? So all these years, like last 10, 20 years, 3-4 decades, many things have happened. Many good things like better education, improving the socioeconomic status, better standard of living, better hygiene. These things have developed, new gene discovery. So that has improved the early diagnosis of the disease, and also probably have changed the biological behavior of the disease because of the nutritional status changes. But at the same time, several ugly things started happening, like increase in alcohol consumption, smoking, industrialization, exposure to processed food toxins. So all these could also contribute to the disease biology. So probably what we have seen, the disease natural history has been same, and the same natural history is seen in patients from the West also. So it is likely that what we used to call tropical chronic pancreatitis patients were seen at the end of the spectrum because of the lack of advanced infrastructure in diagnostics, and people not exposed to healthcare facility, or people not going for healthcare facility. But now the pendulum has swung towards a more milder side, and therefore we probably get the disease that we see, and which we can aptly call as the early onset idiopathic chronic pancreatitis. And this is what the Western literature also describes as two types of chronic pancreatitis: early onset and late onset. And this fits into the early onset variety of idiopathic chronic pancreatitis that is seen in the West. And that could be shaped up by complex gene and gene environment interaction. And then if we look at today's studies, and there was another pan-India study by Dr. Balakrishnan with more than 1,000 patients. So the typical morphology of tropical chronic pancreatitis of the dense calcification, early mortality, early diabetes is only in around 3.8 to 6% of patients today. So this could probably represent the far end of the spectrum of idiopathic chronic pancreatitis rather than a specific disease entity. So now is a difference. So we have seen already that few of the things are actually different between the East and the West. The age of onset is still lower in our patients. The disease morphology appears to be more severe, with bigger stones, more dilated duct, more morphological changes. So this was an interesting study that was published last year, which looked at the, it's a kind of a systematic review, which looked at the differences in the chronic pancreatitis behavior or biology between the East and the West. And they looked at USA, Japan, China, South Korea, India, and so they picked up the published studies. And what they collectively reported was, they said that the disease was kind of consistent. The disease behavior was kind of consistent globally. It was mostly prevalent in middle-aged patients, 40 to 62 years, with an exception in India where still they are calling this TCP, which I don't think is correct. The onset is young. The prevalence of alcohol-related CP is higher in the industrialized nation based on the older studies. In France, for example, earlier studies have shown of almost more than 80% of prevalence. In Korea, 64, 68. But the more recent studies from Japan, Italy, US, and Hungary has actually reported the incidence of alcoholic chronic pancreatitis to be much lower. And what used to be earlier discussed or described as alcoholic pancreatitis was not probably alcoholic pancreatitis in the true sense, because there are many other genetic elements associated with that. Malabsorption and diabetes are similar from the India and the Eastern countries with the West, but what the study reported is more in the West compared to the East, and opioid use, endotherapy, and surgery more in the West. So I think this is a good data, but I still have some reservations in some, because here in the West, even when you look at the East, China or Japan, South Korea, there are more industrialized than the Indian subcontinent. So there could be other factors, and I think it's important to look at the biology for the Indian subcontinent alone and compared to the others, and also from the other Asian countries like Sri Lanka, Bangladesh, Nepal, which do have a significant proportion. So what we did was, based on this,
2 more minutes, Dr.
we start.
2 minutes, please.
Okay, so how many? Two minutes? Okay, I'll be fast. So based on that premise, we had actually started this study called the CIP-CSL chronic pancreatitis in Southeast and South Asia, where we are evaluating the demography, risk factors, and disease behavior from all these countries. And so far, we have recruited 1,500 patients, and where we'll be individually analyzing the data from each country and then compare it with the West. So this is just a preliminary interim analysis. I'll not go through this because this is very rough data which have not completed the analysis. But the important in India are two variants which may have some clinical significance all over the globe, but there are global disparity. And if we see here, the PRSS1 gene, especially the N29I and PRSS1 R122H, these are the two most important genes that are associated with hereditary pancreatitis, which is a 50-fold increased risk of pancreatic cancer. This is common in the West, but fortunately, we do not find these two particular genes in India. We have done several thousands of genetic testing AIMS had done and CCMB had done, but this is the first case report that we could publish which showed a heterozygous phenotype of this. So it's good that we do not have the risk factor for genetic risk factor for pancreatic cancer on the background of chronic pancreatitis. So that is one factor. And the second is cathepsin B, which we find in India, but it's not seen in the West. In all our studies, it's consistently present and it's associated with chronic pancreatitis, recurrent acute pancreatitis, and we have actually shown that presence of the cathepsin B, this particular polymorphism. So this is something that is not seen in the West, and probably cathepsin B is responsible for the lysosomal hydrolase and activation of the trypsinogen. So probably it could have some therapeutic implications in the future. So this is an important difference between the India and the West. And then the other last two slides, other important difference is the response to therapy. So yesterday, Dr. Matthew Philip had talked about this study, the antioxidants that came from Pramod Garg's group several years back, which showed the beneficial effect of antioxidants in these patients. And we had later on again published a combination of antioxidant and pregabalin, which again showed benefit. So why this benefit happens is because in chronic pancreatitis, there will be loss of exocytosis, and there will be minor inflammatory changes within the acinar cells, and that happens because of the interruption or disruption of the methionine cycle or the transsulfuration cycle. So this is the logic of providing antioxidants, and we could show that methionine containing antioxidant, methionine is a donor for this cycle and it restores the cycle, that have a high odds ratio in favor of pain reduction. But then the study from Siriwardena, the Anticipate trial, published again 10 years back, did not show any benefit in this patient. So, and then unfortunately, most of the Western practitioners follow this study. They do not have much belief on antioxidant. But if we dissect out these two studies by Pramod Garg's group and this one, the Anticipate trial patients were older, they were alcoholics, majority of them were smokers, and they had high dose of narcotics. But if we see the Indian study, these patients which showed a benefit, these patients were young, non-alcoholic, non-smoker, and non-narcotic. So they were not given any high potency narcotics. So this is an important lesson. So actually, this study tells us which patients will benefit with antioxidant therapy. And it's important that patients with chronic pancreatitis should avoid high potency narcotics as much as possible. The West has burned their fingers with this narcotic epidemic, and they are trying to correct themselves by reducing the use of this high potency narcotics like fentanyl and morphine-derived nalbuphine. But this is starting in India. That is my concern. We now see lots of prescriptions of nalbuphine in these patients and things like fentanyl. So as long as it is not mandatory, this should be avoided. And this is very important message for the youngsters, the young clinicians who have just started their career. Because if you see these patients, these high potency narcotics have a tendency to cause degranulation of the mast cells, and that in fact increases the inflammation in these patients in the long run. So I think I'll stop here, and in a hurry I could not make a thank you slides, but I think I'll stop here and we'll start the discussion. Thank you very much.
Thank you, Dr. Talukdar, for that wonderful presentation. And the session is now open for discussion. I request participants to put your questions in the chat box so that we'll be able to interact with you. Now, to keep the ball rolling, I would like to ask Dr. Talukdar. See, in India, earlier we used to see the chronic pancreatitis described by Dr. Givargis. Then as Professor Balakrishnan said, now we are finding a change. That means we are finding these people in the third or fourth decade with the less of diabetes, no malnutrition, etc., etc. There is another issue. We were detecting them as chronic pancreatitis, but now we are seeing youngsters with the recurrent acute pancreatitis, and with the availability of US, we are able to say that actually these are chronic pancreatitis, not acute pancreatitis. And the study from All India Institute also alluded to that recurrent acute pancreatitis in India in youngsters actually evolve into chronic pancreatitis. Do you find a similar pattern in the Western studies?
In the West, firstly, the most common risk factor is alcohol. And yes, they do find, that's why now the dynamics of alcoholic chronic pancreatitis is also changing. David Whitcomb has been speaking about this. Even alcoholics are actually genetic pancreatitis. Alcohol is just a trigger factor. So now, even now in like in the West also, the pendulum is shifting towards a more early onset. And when they do EUS, they do find subtle changes of early chronic pancreatitis, even in the alcoholics, and of course, idiopathic is already there. So the dynamics has been changing in the West also, especially if we talk about alcohol-related chronic pancreatitis.
Are you aware of any studies done in India or elsewhere on recurrent acute pancreatitis and its genetics? Because if we understand the genetics, perhaps we may be able to intervene or at least predict the nature of the disease.
So actually, we have conducted a study. We have a data of like more than 750 patients. We are soon going to publish it. We are doing the analysis. What we find is, if there is a combination of gene, for example, SPINK is very common in India, but SPINK by itself is not a disease causal gene. It's a disease modifier. There has to be another risk factor, be it genetics, be it other factors like hypertriglyceridemia, calcium, pancreas disease, that will trigger the disease. What we see is if the SPINK1 gene and the cathepsin B genes are having a homozygous or one homozygous, one heterozygous, those patients are likely to have a disease at a much earlier age during childhood, and they are having many recurrent episodes of pancreatitis, which eventually turn to the chronic. So this is something new and interesting that we are looking at. And more the number of genetic polymorphisms, the higher the risk of recurrent acute and that progresses to chronic. So maybe in the next 6-8 months, we'll be seeing that paper.
Do we have any longitudinal studies by which have shown that by giving antioxidants, we are able to prevent the further progression of recurrent acute pancreatitis to chronic pancreatitis?
That's a wonderful question. We have several patients on antioxidants with recurrent acute pancreatitis. So we have not done designed a very systematic study as yet, but from clinical experience, what we see, and maybe you might have experienced this, especially the antioxidants containing methionine, a high dose of methionine, if the patients are taking, we give it for 3 to 6 months. During that period, they do very well, but once they stop the antioxidant, they will come back with a bout of pain. It may be documented acute pancreatitis or some minor elevation of lipase, but still pancreatic pain. So probably if longer study for several years, we think we might be able to slow down the disease. I don't say we'll be able to revert the disease or make the pancreas normal, because most of these are genetically driven and we cannot change the genes, but at least we might think of reducing the progression of the disease or slowing the severity. But that we need to do a properly designed longitudinal study. But clinical experience, yes, we do think that way.
Professor Kapoor, we don't have any questions.
Can we have some comments from Dr. Puneet, Dr. Ramesh, and Yogesh, because Yogesh has worked all along in Germany. So,
thank you. My question is, since you have also a large database, have you looked for the role of smoking? Because it has become very evident from data from the US, also the SPINK mutation, especially the laboratory it is coming from. I had the honor to invite this person to our center in Hamburg. It seems that smoking is the predominant leading factor.
Exactly,
and if you have in your database this data collected, that you can isolate a subgroup, non-smoker or smoker without alcohol intake and negative for the mutations, and look into how is their disease progression and response to therapy, whatever type of they have got, I am pretty sure that you will find some interesting data to report on.
Agree. Sure. We have done that. We are seeing that patients who are smokers have a faster progression compared to, or alcohol plus smoking has a faster progression compared to alcohol alone. And these patients do not respond to any kind of antioxidant therapy somehow. We have shown in different studies also where we could show that by doing early intervention, we may be able to delay the onset of diabetes. That was a 6-year follow-up study with 506 patients, published, I think, 2-3 years back. So in that cohort of patients also, the patients who had alcohol and or smoking, they did not respond well. In their case, the diabetes did not change, but only in the idiopathic it works. So smoking definitely has something additional to do on top of the usual pathophysiologic events. And in fact, you have rightly said, smoking is much more important risk factor than alcohol. Alcohol is probably just a little trigger on the genetic background, but smoking by itself can cause lots of havoc in the acinar cell.
Quick comment from Puneet and then concluding remarks by Dr. Varghese.
Yeah, one of the questions I've always had is the doctor and the patient both changing their socioeconomic background? The Dr. Balakrishnan second study, which included a lot of centers, Varghese, I think, had contributed the second or the third largest center from. So I think the proportion of patients from the private sector was much higher. So, in the 80s and 80s and early 90s, it was most of the good gastroenterologists were in the public sector only. AIGs and all were not there anywhere. I don't know whether we are. So when I moved to Cochin, I thought I'm going to see patients of CCP every day, but it was just the same incidence as Delhi. So I don't know whether it was because it was and this was a mixed charitable So I'm just wondering what your thoughts are on that.
So So we see patients from all over India, except from Kerala. We don't see, actually. It goes to all of you, Dr. Ramesh, yourself. But we do see lots of patients from Telangana, Andhra, eastern part of India, northeast, even western. So and most of these patients are like not the very well-to-do, especially from the eastern part. I mean, they are middle class patients, and they show the same disease behavior when we compare with the well-to-do and the higher class patients also. So I think the disease behavior is same across the socioeconomic status, and yeah.
And just to answer the previous
Dr.
question, I
Bharti.
think in the list of 1086 patients multi-center study, smoking was there. I think in less than 30%, which
Less than 30,
I also
exactly.
found surprising. Yeah.
Yeah.
But I think it's a very important factor for maintenance. Those who
Right.
get off alcohol and don't stop smoking, the pattern of pain, I think, does continue
True.
unless they stop
Yeah,
smoking
yeah.
as well. So I think
And it's a different-
definitely a co-factor. Yeah.
Right, and it's a different type of pain. They involve more of the nerves. So we are doing several studies on neuropathy, pancreatic neuropathy, and we do see they have a different kind of pain pattern. Like the pain perception is different, and it's very difficult to stop smoking. Patients will easily quit alcohol, but like after all attempts, they can't stop smoking. So that adds to the problem.
Okay, I think we need to. So, Dr. Varghese, any last minute?
Yeah, there is no doubt that the pattern of chronic pancreatitis has changed. It's not only compared to the West, but in our country itself,
Yeah,
it has evolved. It has evolved from the disease of the younger population to disease of the middle age, less diabetes, easy control of diabetes, less complications, and perhaps less surgery. Okay, so the disease is changing, and we are detecting very early cases also. So I think we have to do a lot of research. And one thing is perhaps common, that the disease is more common in the coastal belt, where perhaps the rice eating is more, and one has to look at the eating of carbohydrate, the microbiome, where the fermentation, whether it produces some funny ethanol-like substances, etc., will have to be studied. So it was a wonderful talk, Dr. Talukdar, and thank you for that talk. And I also thank Dr. Kapoor for inviting me. Over to you. Dr.
Thank you.
Kapoor.
Thank you, Dr. Thomas. Thank you, Dr. Talukdar.